Hello everyone and welcome to this episode of Sedaye Daneshjoo. My name is Ryan Fekrat.
My name is Damaris.
And my name is Ida.
Today we're going to be delving into a pretty serious topic, diverging from some of the more lighthearted subjects we've covered on this show. This is the One Big Beautiful Bill Act. So I'm going to go ahead and go through an intro blurb and try and do my due diligence of being as accurate as possible. We are not financial advisors, as I've been myself advised to disclaim. So take this with a grain of salt, but granted, this information is mostly available online, and I'm reciting it to you in hopes that we can spread awareness of this as it's pertaining pretty impactfully to the healthcare professionals that we try to serve on this show. So let's get into it. And we'll open this up to discussion at the end of the show. So the One Big Beautiful Bill Act, signed into law July 4th, 2025, is a sweeping federal budget reconciliation that aims to significantly reduce federal spending on health and social safety net programs like Medicaid and Medicare. To offset tax cuts and meet budget rules like PAYGO, the law makes over $1 trillion in cuts over the next decade, with Medicaid and Medicare as central targets. For Medicaid recipients, it introduces new work requirements of 80 hours per month, for adults without dependents, more frequent eligibility checks, higher cost sharing for some enrollees, restrictions on state financing tools, shorter enrollment periods, and limits on coverage for certain immigrant groups and providers linked to abortion services like Planned Parenthood. Medicare, while not directly restructured itself, faces hundreds of billions in automatic reductions, though through being sequestered, alongside the rollback of a lot of the COVID-era telehealth flexibilities. Supporters of this bill argue that this law promotes fiscal discipline, personal responsibility, while offering some reparations for previously perceived wrongdoings to the taxpayer. And critics of this bill will warn that it will increase the number of uninsured Americans, upwards of 15 million uninsured Americans, strain hospital systems, especially those rural ones, and reduce access to care for low-income families, seniors, and people with disabilities. On rural hospitals, because rural hospitals, which are some of the most disenfranchised, rely so heavily on federal and state funding for coverage, many will be forced to shut down as rural patients become uninsured without access or eligibility to Medicaid and Medicare. General services such as skilled nursing, obstetrics, emergency departments, and some specialty services that take high volumes of subsidized health insurance, as we see in low SES areas, will see huge cuts to their already paper-thin margins, forcing even more providers to relocate their business or force them out of practice, thereby worsening the already desperate medical deserts that exist in rural areas and further contributing to the increasing physician shortage. But who exactly benefits from this process? Well, why are we knowingly worsening this already disparate trend? We don't necessarily have the answers, and any top secret conjecture is just that, it's conjecture. But what we can offer is some insight into some of the major bullets of over the 90-page bill as it pertains to our medical students, residents, taking out loans and paying back their tuition, and more. Some of the most profound changes in the bill involve how pursuing higher education without deep pockets is funded. So this information is most pertinent to pre-meds and medical students, or the following information. On student loans, the undergraduate, annual, and lifetime or aggregate amounts, were we able to find those, Amaris?
So currently there are already capped amounts for the amount of unsubsidized loans students can take out. It is different for undergraduates and graduate students. Currently, the aggregate amounts for undergraduates is $57,500 with a maximum of $23,000 from subsidized loans. And for graduate students, that is a little bit higher. It's $138,500 and with a maximum of $65,000 from subsidized loans.
So those are direct unsubsidized or subsidized loans, and that's for undergrad and grad?
Yes.
Okay. And then let's continue. So this is for our medical student borrowers. So the amounts of $50,000, this is new, the amounts of $50,000 annual and $200,000 lifetime caps will now be in place for federal direct unsubsidized loans for graduate professional programs, for example, MD, DO, JD, etc. And under the One Big Beautiful Bill Act, Grad Plus loans are now gone. A federal loan program, this is Grad Plus, a federal loan program used by over half of borrower medical students to borrow beyond the unsubsidized loan soft cap of institutional tuition, which normally would amount to the cost of attendance, now is being limited to only the cost of tuition. This will be eliminated in sometime July 2026 is projected. There are some changes to public service loan forgiveness. This is a program that I myself only discovered recently, but one that shook my outlook on how I personally plan to go about paying for medical school. This will still exist. However, these new changes would potentially exclude residency and fellowship years as counting towards PSLF for new loans taken out after the enactment date, sometime circa July 2026. And let me stress that current med students and residents can still be affected by this change. So let's move on to debt repayment. So ways to pay for medical school, ways to repay debt. Let's talk about scholarships and funding tuition. So just like always, you can always borrow your federal direct unsubsidized loans with these new annual and aggregate caps of $50,000 and $200,000 respectively, but beware that those caps are now instated. Federal grants also exist, such as the National Health Service Core Scholarship, providing tuition and stipend for service commitment under certain areas upon graduation. It's a similar avenue and service orientation to PSLF, or the Public Service Loan Forgiveness. And there is also a similar scholarship that exists in Military Corps, Air Force, Navy, and Army. All have a similar scholarship called HPSP, Health Professional Scholarship Program, that has a service requirement to whichever branch you sign with. We can get to that later. Need-based scholarships are offered by institutions, as always, along with merit-based and specific criteria-based scholarships. This accounts for only a small percent of students that acquire need-based scholarships, or merit-based. I believe it was somewhere in the line of like less than 5%, 5%. And then those that take those, like the Health Corps and the HPSP, is somewhere in the vein of like less than 2% of all borrowers, or not all medical students. And if you're curious, it's somewhere around 30% that do not take out loans. I believe it is 25%, 30% that graduate with no debt, something like that. Oh. And the reason that is because there is a disparity that exists in the class of those going in. Something in the lines of there are as many medical students, and we just watched this morning. There are as many medical students in the top 5% of income as there are in the bottom 50%. So same number of medical students that are super rich as there are, right, there's a huge disproportion. And this, I mean, at face value, seems to worsen that in future trends. Okay, so there also, and we just talked about this, there also exists a small minority of students that take scholarships that are also taking military scholarships, like I myself intend to do, like HPSP, which is a 1 to 4 year scholarship which exchanges some of your freedoms, we can talk about that in the discussion afterwards, some of your freedoms post-graduation for full tuition and stipend. And then there's general medical scholarships with a different eligibility requirements and awards that vary. Hopefully somewhere in here we talk about Pell Grants as well, as those are impacted. Free tuition. So these are those schools that have deep pockets. They have proprietors that have paid them out sufficiently that they have enough funds to pay for in perpetuity the tuition of their students. To my knowledge, there are 3-4 programs we have on here. There's NYU Grossman School of Medicine. This school is on the higher tier of admissions requirements, specifically with numerical requirements. There is the Uniform Service University, which is basically military medical school. This is a federally or publicly funded medical school, publicly delivered and publicly funded medical school like a veteran healthcare system. But you also owe a larger than HPSP, which applies to all schools. We'll get into that later. You owe a larger service to the amount that you are awarded in school after the fact, upon graduation. There's Albert Einstein College of Medicine in New York and the Bronx. They offer free tuition. Cleveland Clinic Lerner College of Medicine, restricted to one of their colleges. This is an arm of Case. This is the college itself. This is an arm of Case Western Reserve School of Medicine. It's a 5-year research intensive program. And then Washington University School of Medicine, they offer reduced tuition based on need and merit. They also offer full tuition and stipends for MD, PhD candidates. To note, so let me clarify, MD, PhD candidates, any school that is under the NIH funded MSTP program, you'll be awarded full tuition and stipend. However, that comes hingent on the fact that you need to pursue 8 to 10 years of medical education before you can go into residency. Important to note that coverage of tuition does not include living expenses and other educational fees. And those Grad Plus loans that you would take to meet that borrowing amount are now gone. So the big ones, student loans and how to pay them back. Being that Grad Plus is done away with means that we have capped direct unsubsidized loans remaining with fixed interest rates, income-driven repayment plans, and more in terms of changes. You need to be aware of the potential hazards and pitfalls that exist so you don't fall into that $1.2 billion in total loans that are still being repaid by those physicians and graduates, more than that, more than $1.2 billion and those that are 62 years of age and older. You need to be aware of the potential hazards that exist in these plans, and that choosing one that fits your family and needs on a case-by-case basis is necessary. In other words, plan to equip yourself in the years to come if you're pursuing medical education in the United States with a calculator and project some of these numbers for yourself. You need to follow the plan that costs you the least amount of money. As we were previously under IDR, income-driven repayment, there were many loan repayment plans. There was Save, there was Pay. Majority of cases, there will only be 2 repayment plans now, this being the standard plan and the repayment assistance plan. Let's talk about the major bullets of the standard plan. This is a minimum fixed payment amount, and it's adjusted initially based on the borrowed amount. That is both the loan repayment period and the amount that you pay. There is no loan forgiveness for this. Even if you make payments up to a certain time frame, the time frame on these is more what previous borrowers should be accustomed to in the timeline of 10 to 25 years. So more like the timeline of previous loan repayment plans, but there is no loan forgiveness to these, so you can't do PSLF with a standard plan. You will pay less interest overall on this plan, however, because the schedule is shorter and more of your balance is paid earlier. However, if you don't have those funds up front, you're going to need to choose another plan, and there's only one other one. That's RAP, or the Repayment Assistance Plan. This is the AGI, or Adjusted Gross Income Plan. This is an extended payment plan of up to 30 years based on amounts of loans taken. And for most of us intending to go into medical education, this is going to be 30 years. You're going to max out the timeline on that plan. RAP does count towards PSLF, but, and this bill is currently going through the Senate as of the time of this filming, it's up in the air whether or not an amendment is going to be made to residency years counting towards your PSLF, which I believe it's pretty standard for it to go up to 10 years in repayments. Working in a public service and residency, most count on that to make those payments happen. And they'll typically go on the lower end of possible payments, go through public service on a previous plan that's income adjusted, and then by time they graduate and then in a shorter amount of years after, they have the remaining balance forgiven, which is awesome. That may no longer be available. RAP, more on RAP, longer total repayment periods than most standard plans for med grads. It is based on your AGI for your monthly payments. However, deductions occur for your number of dependents. And speaking of dependents, Parent Plus loans. So here's what's going on with Parent Plus. This is all information freely available online, and I'm not a financial expert, but to the best of my knowledge, if you have consolidated your Parent Plus loans into direct consolidation loans, and have enrolled in the income contingent repayment plan before enrolling in income-based repayment as of July 2026, you are eligible to enroll in continued Parent Plus to offset extra costs of dependents, but you got to do it before it's too late. Too late would be 2026 to around July 2026. To note, Parent Plus is now capped at 20,000 years as 20,000 per year. 20,000 years, as where previously it was not, with a $65,000 lifetime max per student, so per family. This is not adjusted. The lifetime max is not adjusted per child. As for the income-based repayments, this is one of those previous repayment plans. This mostly applies to current borrowers, but you can enroll in these plans as a cheaper alternative. Always go with what's cheaper until sometime circa July 2028, sometime between 2028 and 2026. This is ongoing debate on when this is actually going to roll out, at which point then the proposed legislature has these plans, the previous IBR completely eliminated. New borrowers post that period will have to choose between standard and WRAP. You can't go to the previous IBR. Let's go back to loan forgiveness, the PSLF, for a little bit. PSLF is largely unaffected under those enrolling in WRAP. So if you plan to go the service route for repayment, plan to enroll in income-based repayment options and be sure to exhaust your forbearance if applicable, while being aware that forbearance itself for your graduate program loans, who qualifies for it and how long you can take in a fiscal year is being shortened and curtailed. Forbearance periods are being shortened with longer cool down periods before you can redo a forbearance period. So but beware that current legislation is volatile and there is the potential that residency hours, again, may not count towards that time served. Additionally, with these new aggregate and annual loan amounts, understand that standard repayment and WRAP only apply to that money borrowed via those direct unsubsidized federal loans for graduate professional programs. If you take a private student loan, you can't use PSLF to repay that or have that forgiven. Finally, we'd like to mention some overall good practices for medical students and residents going into this next chapter of life. Formerly federally funded elements of social programs like SNAP, Child Tax Credit, WIC are either being revoked or restricted, and so expect reliance on these programs to be less stable. However, we encourage low-income and trainee families still in residency to continue to seek out these programs to offset some of those payments and any other social programs and low-cost options that you can, as many as you can. Use these programs, which were designed for pre-professionals like yourself, to support yourself and your family during these training years. And thank you for putting up with that little blurb. So let's open this up for discussion. I had mentioned that there is debate on who's a winner and who's a loser in this situation. I can talk about HPSP, but one of the things I want to get off my chest is osteopathic schools. Osteopathic schools, I think, are pretty big losers in this process. I'm not calling them like a loser, but they're losing out in this bill because the cost of attendance at osteopathic schools is greater. At the same time, the schools themselves may benefit because their students ultimately have to pay these things off, but less students may want to attend osteopathic schools because they are more expensive, may drive people away from that. Can talk about the implications for their professors as well, their PhD professors, but basically it's more expensive, and for the schools themselves, the tuition and fees accounts for about 50% of their income, of the school's income. I mean, it's a business. And so we may even expect that number to change, and that significantly affects the school. It might change. They might bring the cost of attendance down. But the thing is that in the bill, there's nothing that mandates that cost of attendance go down. What do you think will happen? What do we think will happen to those schools?
It sounds like it's just going to be more difficult. So if you're already having a hard time in financially, it just sounds like it's going to be more difficult in the future, and that might maybe sort of lower the rate of physicians that we have currently.
Yeah.
They might try to view different avenues and different options in medicine rather than going towards being a physician. And I think it maybe physicians that are currently in medical schools might, if they're stuck between primary care or like a higher specialty, then they might feel more maybe encouraged or motivated because of these new laws going in to go towards the specialty that's higher income. So I think it might reduce maybe the overall physicians we have. And
GPs.
Yeah,
Number of
definitely.
GPs.
Yeah, I totally agree. I think it's just going to potentially exacerbate the physician shortages that we are already experiencing. And I think the expected amount is what? 187,000 by
Yeah, it's
2037?
expected 2037, 187,000 physician shortage.
So I think, just like you're saying, Ida, that people are probably going to seek other careers in healthcare that are a little bit more affordable, like perhaps physician assistant or NP or something where they can not be in school for so long and start to make money in their career sooner than going to medical school.
Or just forego any type of clinical medical education entirely. And then we'll have an even greater shortage. And there's a shortage in other healthcare jobs as well, PA and NP nursing. Nursing shortage is the other big one that gets thrown around. It costs money to go to these programs.
Yeah.
And these are our loan caps that apply to graduate and professional degrees. We had a guest on previously, Caitlin, who was a PA student. She's a PA student. And I believe we asked her, you know, does your degree count as a professional or a graduate program? Because they're actually different under, the two are different under this bill. One of them, I think the borrowing aggregate limit is 100,000 and the other is 200,000, double that. It's less, but the competitiveness is comparable, like specifically PA programs. The cost of attendance, or the total cost of attendance per year, is also comparable to medical school. And 200,000, I mean, the average cost of medical attendance is somewhere in the range of 270,000. And so this doesn't even cover that. It forces students who are relying on borrowing loans to seek out private student loans, or it forces them. And I mean, and these are people that, you know, assuming that you don't have parents with deep pockets who are just going to pay for your school. So it does increase the disparateness in who has access to medical education, not who has access to medicine, but who has access to medical education, right? And we know this in research that, let's say I am a white male. If I have a white male doctor, my outcomes are projected to be better. If I am a Hispanic, Latino, or Latina female, and my doctor is the same ethnicity as me and same sex, I'm expected to have better outcomes. Same goes for every ethnicity and all that. And why is that? It's psychology, social psychology. This is what social psychologists say.
Seeing yourself reflected in medicine, I think, has that effect. So I think for those reasons, diversity in the field is important. And I think that this is just going to make that worse. It's just going to put a further gate in front of going to medicine in a general sense, not just going to medical school, but also just healthcare careers in general. For people that are very wealthy, who have parents that can pay for their school. Otherwise, it just doesn't seem like it's financially even a smart idea to go to medical school if you really can't afford it. And you can't even take out loans to be able to do that.
Yeah, these private student loans, the interest begins to accrue as soon as you sign that note, right? As soon as you sign that note, your interest begins to accrue. There's no forbearance or deferment, you know, till after. It's not as generous as these federal direct unsubsidized loans, and so it presents the question, you know, this is like knowingly dangerous and disparate to prospective medical students. What is the purpose of this? And yeah, like they have a $50 billion health fund to rural medicine, that I doubt, you know, this is just personal opinion and conjecture, I doubt it will cover the cost and the losses in Medicaid, Medicare payments to rural hospitals, especially over the long term. Like, what's the plan? And then what's the plan with this physician shortage? You know, who is championing this knowledge, the physician shortage? What's their benefit? What's their angle? And then why do we not seem to care as a country about worsening it? There's a lot of different angles to take this, but that's all for now. Thank you guys and everyone for watching this program, and until next time.